This is the second lecture of the drugs used to treat the bronchial asthma. At the end of this lecture, you will be able to describe the drugs used as long-term controller of bronchial asthma, and we can discuss the drugs as prophylactic agents, and you will be able to outline the management of status asthmaticus. This is the pathogenesis of the bronchial asthma and the targets drugs for the drugs we use in the late response inflammation and the bronchial hyperactivity. We'll treat with the steroids, cromolyn, nicotine antagonist, and we can avoid this the antigen antibody reaction in the mast cells, and they stabilize the mast cell. We use the steroids, cromolyn, and zoellatin and antibodies, and they can decrease the release of the mediators. This portion we have already done the early response of bronchoconstriction. We have treated with the bronchodilators. Similarly here, the targets of the controller drugs is like corticosteroids is a phospholipids. Phospholipase inhibits phospholipase A2 enzyme, which converts the phospholipids into arachidonic acid, and all the following process is inhibited. Similarly, we can use the lipoxygenase inhibitors, which inhibits the lipoxygenase the cycle, and no leukotrienes are formed, which causes bronchoconstriction and the inflammatory cell infiltration. We can, at the receptor level, we can use the leukotriene antagonist, which inhibits the inflammation and prevent the bronchoconstriction. Inflammatory agents or controllers. Number one is our corticosteroids. Corticosteroids are inhaled form. These are beclomethasone, budesonide, and many others, and oral and injectable form. You will have to memorize all of these drugs will use as inhaled or oral agents or injectable agents, especially in the follow-up treatment of the bronchial asthma. What is the mechanism of action of glucocorticoids in bronchial asthma? You already know glucocorticoids from your physiology. Normally, we know that they do not relax bronchial smooth muscle directly because they have no direct effect on the smooth muscles of the bronchi. They decrease the bronchial reactivity, and they decrease the frequency of the asthma exacerbation. Glucocorticoids binds to intracellular receptors and activate glucocorticoid response element in the nucleus. You know that this is the nuclear receptors. They decrease the synthesis of the substances that provoke the full expression of the inflammation and allergy. Full expression of inflammation and allergy, like decreasing the formation of the proteins available for them, right? They have anti-inflammatory effect in asthmatic airways. They inhibit the cytokines which initiate inflammation, provoked by antigen inhalation or viral infection. They inhibit the phospholipase A2 and inhibit the arachidonic acid formation and decrease the synthesis of leukotrienes and prostaglandins. Leukotrienes are extremely potent bronchoconstrictor and may also participate in the late inflammatory response. So they inhibit the bronchoconstriction, lymphocytes, and eosinophilic mucosal inflammation. In this way, they play a main role in the follow-up or in the additional late response of the bronchial asthma. And contributory mechanisms are they potentiate the effect of beta-2 agonist. When we are already using beta-2 agonists and bronchodilators, and they potentiate the effect of beta-2 agonists. Constriction of the engorged blood vessels in the bronchial mucosa is also decreased, and they help in decreasing the obliteration or obstruction to the airflow. Clinical uses of bronchial asthma, corticosteroids in bronchial asthma. They are not curative agents. They improve all the indices of the asthma control. They decrease the symptoms. They decrease the test of, and they improve the test of airway calibers. They decrease the bronchial reactivity. They decrease the frequency of the exacerbation, and they improve the quality of life. And they also decrease the requirement of beta-2 agonists. Normally, they are not curative. We said that. Now, how we use these agents in bronchial asthma? In chronic bronchial asthma, if symptoms persist despite the bronchodilator therapy, inhaled corticosteroids should be started. Like these are the all inhaled corticosteroids, glucocorticosteroids. Combination of inhaled glucocorticosteroids with beta-2 agonist in a single inhaler are commonly prescribed, like fluticasone and salmeterol combination is coming, and budesonide and formoterol. These are long-acting beta-2 agonists. These are the inhaled corticosteroids. They are combined in a canister, and they can be inhaled morning and evening. They have long duration of action, and they prevent the persistence of the bronchial asthma. In severe cases, sometimes combination with inhaled oral therapy is started. After giving the bronchodilator, whether beta-2 agonist or some others, 30 to 60 milligram prednisone daily for 5 days or longer, or intravenous methylprednisone 1 milligram per kg 6 hours is given. After improvement, oral dose is gradually decreased over 7 to 10 days if it has been started for longer time, and inhaled corticosteroid is continued. In acute asthma, severe asthma, we give intravenous hydrocortisone 200 to 300 milligram intravenously, or methylprednisolone 1 milligram per kg 6 hours, followed by oral prednisone or prednisolone 0.5 milligram per kg every 6 hours. You see here, we do increase the dose in severe acute asthma. Advantages of inhaled glucocorticoids are as same like that we have seen in bronchodilators, self-administration, rapid onset of action, less doses are required, greatest effect in bronchi, less systemic effects of toxicity, and better effects when used with spacer. Spacer, I have shown you in the last lecture. Spacer is a large volume chamber attached to a meter dose inhaler. Spacer decrease the deposition of the drug in the mouth caused by improper inhalation technique. And you can see from here, this is the canister containing the drug, and this is the spacer through which the patient can breathe for a longer time, and so that all the drug can be entered into the lungs. There are some potential adverse effects of inhaled corticosteroids, like oropharyngeal candidiasis can occur, hoarseness of voice may occur because of the because of deposition of glucocorticoids, this risk of osteoporosis and cataracts on the long-term use. Transient growth retardation in children, that is although negligible, this retardation of vertical bone growth secondary to low oxygenated blood levels from uncontrolled asthma can occur in most severe cases. Adverse effects of oral glucocorticoids. On short-term use, we have adverse effects on long-term use. On short-term use, like less than 2 weeks, acute peptic ulcers can occur. Initially, insomnia, euphoria, and subsequently depression may occur. Large doses may increase the intracranial pressure. These are the adverse effects on short-term use. And when we use the drugs on continually more than for 2 weeks, we have many other adverse effects like iatrogenic Cushing syndrome may occur because of excess of glucocorticoids, gastric intolerance. It can increase the susceptibility to infections, growth retardation in the children, and myopathy may occur. Psychiatric disturbances are there. Ocular side effects like cataract and glaucoma may be there. Miscellaneous toxic effects will see an increased mineralocorticoid activity may be there. Suppression of hypothalamus pituitary adrenal axis because of for this normally we taper the doses in the end after 7 to 10 days, but on continuous use this can be occur, and this can create a crisis of the patient. Then come the anti-IgE therapy. Omalizumab. Omalizumab is an antibody. It is a DNA-derived humanized monoclonal antibodies raised in the mice. It is targeted against the portion of IgE that binds to its receptor on the mast cell and other inflammatory cells. That means that it will neutralize the effects of IgE, especially on the mast cells and other inflammatory cells, and they will prevent the release of inflammatory cytokines, chemokines, and other mediators. Like this, you can see from here, omalizumab, how they decrease the mediator release, from the inflammatory cells. They bind to the free IgE in the circulation. They reduce the eosinophil in blood, sputum, tissue, decrease the high affinity receptor expression on eosinophils, decrease the IgE production from the beta cells, and they decreases the IgE related facilitation of an antigen presentation, especially from the allergen, so that the initial process is not there, right? In this way, it decreases the allergic response to to all these mediators. Especially you can have it inhibits the binding of IgE to its receptor mast cells, basophils, does not activate IgE already bound to these cells, thus does not provoke degranulation. It prevents the degranulation of the mast cells and other cells. Can decrease early and late bronchospastic responses to antigen challenge, decrease the severity of asthma attack, decrease the corticosteroids requirement. In this way, it also neutralizes the circulating IgE antibody. It can lower the plasma IgE significantly when given for more than 10 weeks. In this way, it helps in the controlling the bronchial asthma and inflammation. May inhibit IgE synthesis by lymphocytes. What are the therapeutic uses of omalizumab? It is given intravenously or subcutaneously. In chronic severe bronchial asthma, we demonstrated IgE-mediated sensitivity. We always give the patient to the patient who have already shown that we are tested for IgE-mediated sensitivity or in inadequately control of high doses inhaled corticosteroids or long-acting beta-2 agonists. Why we say these are the preliminary conditions to give them, because it is very expensive also, but because patient is having chronic severe bronchial asthma, we can relieve the patient from this situation by giving omalizumab. Perennial or seasonal allergic rhinitis and conjunctivitis can also be treated with omalizumab. There is no adverse effects of omalizumab except that hypersensitivity reaction to the patient of already hypersensitive to many things. It is very expensive otherwise. Other anti-inflammatory therapies like we already know etanercept. It's an immunomodulatory therapy recently reported to improve asthma, and injection of etanercept can be given. Etanercept, what is etanercept? It is an TNF alpha antagonist used in the treatment of ankylosing spondylitis and severe rheumatoid arthritis. We have also already studied this agent in the NSAIDs and when we have done the DMARDs, one of the DMARDs. Now, what critical thinking I have put here this slide because you can so that you can become familiar with the other drugs used in treatment of the bronchial asthma, how they are effective in preventing the bronchial asthma, which drugs can decrease the mediator released by the action of acting as 5-lipoxygenase inhibitor. This is just a repetition of that figure. Can we prevent the bronchial constriction by nicotine receptor antagonism? What is the role of anti-IgE therapy in resistant cases? How will you plan a strategy to treat COPD? Outline the management of status asthmaticus. These are the thinkings. These are the small SCQs you can solve after studying this lecture. Especially, I have put them here because it can be helpful to you. Otherwise, although I'm not putting them in the assignment. Drugs used for the prophylaxis of bronchial asthma. Chromalin sodium, disodium chromoglycate, it is also called, or nitrochromyl sodium. There are two agents. They are synthetic agents. They are given by inhalation and in adults by meter dose inhaler 2.54 milligram 4 times daily. In children, aerosols of 1% solutions are there. By inhalation, we use in adults and children both. Or we can use them as a nasal spray or eye drops. Sometimes we use them as nasal spray and eye drops in conjunctivitis or in nasal rhinitis. Mechanism of action is previously they were called mast cell stabilizer. Recently established to improve They produce the alteration in the function of delayed chloride channel in the cell membrane, inhibiting cell activation of important cell. They have effect on airway nerves, suppresses cough. On the mast cell, they prevent the degranulation of the mast cells and release of mediators. Effects on eosinophils, there is avoidance of late response. They will decrease the late response, or we can avoid the late response. There is no effect on airway smooth muscle tone and are ineffective in reversing the bronchospasm once it has been there. So they are only of value when taken prophylactically. So they prevent the bronchial asthma normally. Primary prophylactic we use cromolyn at all ages, and nitrocromil only not below the 12 years. After the 12 years of age we can use them. For prophylaxis of bronchial asthma due to exercise, exposed to sulfur dioxide, occupational and other unavoidable allergens, exercise, they decrease the exercise-induced bronchial asthma, and the bronchoconstriction or bronchial asthma after exposure to sulfur oxide or other occupational and unavoidable allergens. The acute protective effect of a single treatment makes formalin useful for administration just before exercise or exposure to unavoidable allergen. Just like said, say we can see before starting the exercise, you can have an inhaler of this, and similarly before going, you know that before going to that place, you can avoid this allergen by having the exposure, by having the inhalation of this drug before going to that place. Similarly, for allergic rhinitis and rhinoconjunctivitis, as a nasal spray or eye drops several times a day, effective in 75% of patients, even during the peak pollen season. This is given in the patient who are not treated, not they are not getting benefit from other antihistamines, and like that we use the allergic these patients in as eye drops or in nasal drops. There are few adverse effects. After, you can say there are minor localized at the site of deposition. These are the common throat irritation, cough, dryness of mouth. Sometimes rare chest tightening and wheezing may occur, and these can be prevented by prior inhalation of beta-2 agonist. So beta-2 agonist inhaler, once you use that, and after that you use this inhaler. Serious adverse effects are rare. Less than 2% cases may have reversible dermatitis, myositis, gastroenteritis, pulmonary inflammation with eosinophilia, or anaphylaxis. Very, very rare cases. In very rare cases. These were the adverse effects of cromolyn and nitrothromal. Now comes the leukotriene pathway inhibitors. There are 5 lipooxygenase inhibitors like xylotine and leukotriene receptor antagonists, montelukast and zafirlukast. Pharmacokinetics of leukotriene pathway inhibitors. They are effective orally. Food impairs absorption of zafirlukast. Plasma protein binding is 90% and they are extensively metabolized. Montelukast and zafirlukast are excreted in the urine, and xylotine is excreted in the bile. Xylotine is the 5-oxy lipooxygenase inhibitor. Let's see the mechanism of action of xylotine. Xylotine selectively inhibits 5-lipooxygenase pathway and inhibits the synthesis of leukotriene from the arachidonic acid. 5-lipooxygenase pathway is the enzyme found in mast cells, basophil, eosinophil, and neutrophil. In this way, all the anti-inflammatory effects of all these mediators can be released from these cells can be prevented. Xylotine decreases the synthesis of LTB4, leukotriene B4, and cysteine leukotriene like LTC4, LTD4, LTE4. They prevent the bronchoconstriction, microvascular leakage, and mucus secretion produced by cysteine leukotrienes, and they inhibit the eosinophil and basophil influx due to LTB4. We already know this LTB4 induced the phagocytic migration and eosinophil and basophilic influx into the site of the inflammation. We know from the gout, we have treated this patient when we have seen the treatment of gout. Hence, useful in preventing the bronchial asthma, right? It has inhibit the 5-lipoxygenase pathway. It is useful in preventing the bronchial asthma. Leukotriene receptor antagonists like montelukast and zafirlukast, they are competitive antagonists of LTB4 receptors and blocks its effect. They prevent the bronchoconstriction, they inhibit the eosinophil basal influx due to LTB4, and hence they are preventing the attack of bronchial asthma. In this way, we can use these drugs in prophylaxis of bronchial asthma, right? Next comes up. You can see from here the figure how they are formed. Xylotine inhibits the production of all the leukotrienes, and montelukast and zafirlukast, they bind to the receptor and they are receptor antagonist at the site of airway smooth cells. Therapeutic uses of these inhibitors. They are used as prophylactic for mild asthma, prophylactically for mild asthma, especially useful in aspirin-induced, exercise-induced, and antigen-induced asthma. They improve asthma control. They decrease bronchial reactivity and airway inflammation, but are less than inhaled corticosteroids. They can decrease the frequency of the asthma exacerbation equal to inhaled corticosteroids. So they are sometimes used in combination to corticosteroids. Adverse effects of nicotine pathway inhibitors may be generally the receptor antagonists are safer drugs. Common adverse effects are headache, dyspnea. Zafirlukast and zolotine inhibit cytochrome P450 enzyme, so they can increase the level of warfarin. And rarely, Shrug-Strott syndrome may occur with all these agents. This is a systemic vasculitis characterized by worsening asthma, pulmonary infiltrate, and eosinophilia. Xylotine is hepatotoxic also. As we have seen, it is metabolized in the liver and excreted in the bile. So sometimes hepatic patients should be given with care in hepatic disease. Patient with hepatic disease, we should give them with consciously. This is a stepped approach for managing asthma. We'll start from the short-acting beta-2 agonist in acute patient. If it is not relieved, we add the low-dose inhaled corticosteroids. And number 3 comes in for the control of the repeated attacks of the bronchial asthma or persistence of bronchial asthma. The control is these drugs with long-acting beta-2 agonist and low-dose corticosteroids or medium. Then if it is not relieved with it, then we go on medium dose in corticosteroids and the long-acting beta agonist. And the next stage comes if the patient is not relieved and patient is not getting benefit from this, then a high dose corticosteroids and inhaled corticosteroids and the long-acting beta-2 agonist, and we add sometimes omalizumab. In the last stage, in the term, and then we all have these are the stages how we can treat the patients with manage the patients of asthma in different stages: acute stage, long-term persistent bronchial asthma, chronic bronchial asthma, and sometimes exacerbation of acute and chronic, and the severe bronchial asthma can be treated by high dose inhaled corticosteroid, long-acting beta-2 agonist, oral corticosteroids can be added. Sometimes we have to give an intravenous corticosteroids, and that considered the omalizumab. This is the stepped care or approach. How can we manage the asthma, especially? Then comes the management of the acute severe asthma. Management of severe acute asthma or status asthmaticus. It is patient is treated in the ICU with continuous clinical assessment and repeated objective measurements of lung functions and blood gases. And oxygen inhalation, humidified or mask to the liquefied mucus is the number 1 treatment. We always keep ready oxygen. And number 2, we can, in severe attack, we can We can bronchodilate the patient with epinephrine. Epinephrine, as we have seen, it is given in 0.4 ml of epinephrine. 1 in 1,000 solution is given. It is given by subcutaneous injection or by inhalation, 320 microgram per puff. Maximum effect after inhalation in 15 minutes can occur. Duration of action is 60 to 90 minutes when we give epinephrine, and it can be repeated if the heart rate remains less than 100 beats per minute. And at the same time, we listen we auscultate the patient, and bronchoconstriction is relieving, and heart rate is not more than 100 beats per minute. We can repeat the second injection of the epinephrine. And then we give the salbutamol, the nebulizer. Salbutamol nebulization 2.5 or 2-3 milligram over 3 minutes. We can repeat in 15 minutes. Here we avoid any kind of sedation. We do not give a patient, because otherwise patient is anxious. There is anxiety in the patient, but we do not give sedation of any kind because we have to see the response first. See, we add the glucocorticoids, intravenous hydrocorticosteroids 200 to 300 milligram, 300 given stat, or intravenous methyl prednisolone 1 milligram per kg 6 hourly is started. It is followed by oral prednisolone when patient is settled, 0.5 milligram per kg every 6 hours for at least for 5 to 7 days. It is tapered around after the 7 days if we have to use to for more than 7 days. Then we can give aminophylline. We have seen that aminophylline can relieve the bronchodilation. It can an add-on reaction to beta-2 agonist, and it can enhance the effect of glucocorticoids. 250 milligram intravenously slowly over 20 to 40 minutes, or we can give in infusion form. Ipratropium sodium bromide, ipratropium bromide by nebulizer or inhalation can add. And the appropriate antibiotic is added if we suspect that there is bacterial infection. Similarly, patient can be intubated and mechanical ventilation can be given. This can be helpful if there is respiratory failure is going to, and we are seeing the respiratory failure is impending, then general anesthetics are required. This is the outline of treatment of bronchial asthma. And in stepped condition, fashion, we can start from this epinephrine, salbutamol, then glucocorticoids, aminophylline, ipratropium, bromide inhalation, and appropriate, and then we will have the review of the treatment after the condition is settled down. After reviewing the condition, will start the patient on oral therapy, and to the treatment of COPD, chronic obstructive pulmonary disease. How we treat the COPD. COPD is characterized by progressive airflow limitation, not fully reversible with bronchodilator treatment. 85% cases are smoker here, and the loss of functions, especially progressive loss of functions, are especially associated with continuous smoking. Most often triggered by viral or bacterial infection. It occurs in old patients, and it is associated with neutrophilic rather than eosinophilic infiltration. See, there is no eosinophilic. This is not allergic reaction. This is maybe this is acute infection, exacerbation with acute infection, poorly responsive to even high doses of corticosteroids. High corticosteroids कभी ये इतना response नहीं करती. So ट्रीटमेंट कैसे हम करते हैं? फॉर कंट्रोल ऑफ एक्यूट सिम्टम्स, ड्रग्स ऑफ चॉइस आर शॉर्ट एक्टिंग बीटा टू एगोनिस्ट, salbutamol. We do not give by inhaler because inhaler lung surface is not that much available, so we give mostly by intravenous, orally. Antimuscarinic drugs, ipratropium, or combination of both drugs. This we give from within by inhalation, and salbutamol sometimes we use orally. The persistent symptoms of dyspnea and limited activity के लिए हम क्या use करते हैं? Long acting beta 2 agonist, salmeterol or indacaterol, and long acting muscarinic drugs like tiotropium and Dinium. These are the drugs we use for as inhalers. For severe airflow obstruction and prior to exacerbation, we use inhaled corticosteroids. We add theophylline to help the corticosteroid that improves the contractile process, function of the diaphragm also, respiratory muscles की contractility भी ये बेहतर कर देते हैं. And role of antibiotic is that more important. Exacerbation always involves bacterial infection of lower airway more than asthma. The COPD is treated by this, like this. Thank you very much for this lecture. And if you have any query, uh, you can contact me or send me your queries on the site.